I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from Canada, and I'm here with Professor Wilfried Mullens, the Principal Investigator of the ADVOR trial that he is presenting at ESC 2022. Welcome, Professor Mullens.
Thank you. It's a pleasure to be here.
Your trial has generated much excitement, partly because of the burden of heart failure on hospitalizations, healthcare resource utilization, and the issue of decongestion and how persistent congestion is associated with rehospitalizations. So you sought to answer an important clinical question. Tell us what that question was.
Yeah, like you're alluding to, I think the trial was designed in the most difficult area within cardiology to show a positive endpoint. And that's the patient admitted with acute decompensated heart failure. We know that many trials have failed to reach their primary endpoint. So we set up the trial very meticulously in the hope that we could reach a very important clinical endpoint of decongestion. And what we did is we compared the classical therapy, which is a standardized scheme of diuretic therapy with loop diuretics plus placebo, versus the same standardized loop diuretic therapy plus the old drug like you were referring to, acetazolamide. Acetazolamide is a very old diuretic agent that blocks sodium uptake in the proximal parts of the kidney, and we've shown before that that can boost the diuretic efficiency of loop diuretics.
Now tell us how you sought to establish the appropriate loop diuretic dose for the control group.
Yeah, we looked back at the data that was available from other randomized trials, and there's only one, that is the dose trial. And what turned out to be most effective in the dose trial, which we also incorporated in our Heart Failure Association algorithm in Europe, is twice the home dose. So when the patient came in, for example, with 2 milligrams of bumetanide, we gave him 4 milligrams a day. First day, bolus 4 milligrams, and the second day we split it, the amount in 2 doses.
Okay, and you switched from oral to IV therapies.
Exactly.
Right.
Yeah.
And did you titrate those to urinary sodium or use any objective measures of decongestion in the control group?
So we strongly believe in urinary sodium as an indicator of a diuretic response, but that's too early to adopt in a trial. So what we did is we trained the investigators to do their best job to assess congestion on a volume overload basis. So we trained them to look at edema on the legs, to rule out pleural effusion and ascites. For the latter two, they needed to use technical exams, a chest x-ray or an ultrasound for the pleural effusion, ultrasound of the abdomen for ascites. We also collected urine for the first 2 days. And if the patient did not make enough urine, defined as less than 3.5 liters, in both groups, the physician needed to escalate diuretic therapy. And there were several options to do so.
Okay. So the same dose of IV diuretic in both groups plus acetazolamide in the treatment group.
Exactly.
Okay.
Yeah.
So tell us about your baseline characteristics.
Yeah. Well, they're really real life patients, you know. They're 78 years of age. Median NT-proBNP was 6,200, GFRs of about 38 with a lot of comorbidities. 60% were male, 40% were female, so also on the gender we had a good balance. 2/3 were HEF PEF and 1/3 was HEF REF. So this is actually what we're seeing. Our emergency rooms are floating with all these type of patients, elderly with a lot of comorbidities.
Right. And were there any patients that were not represented in this trial, or what were the exclusion criteria for the trial?
I think what is one of the limitations mentioned in the New England Journal is that it was a trial only recruiting patients in Belgium. So that's mostly 99% the Caucasian population. So we cannot extrapolate the data perhaps to other ethnic people. So that might be a limitation, but the main inclusion criteria, it was a pragmatic trial, was straightforward. There was acute decompensated heart failure, volume overload, already on a loop diuretic at home, and NT-proBNP levels above 1,000.
Okay. And you excluded people with very reduced GFR and hypotension?
Yeah, so we excluded patients from which we knew this is not going to be of benefit. So if their GFR was below 20, if they were on precardiogenic shock, defined as a blood pressure below 90 systolic, and we also excluded patients on an SGLT2 inhibitor. And I know you're going to ask the reason for that, so I'm going to allude that already. SGLT2 inhibitors were not indicated for heart failure nor approved when we started the trial. So we did not want to have a disbalance in two groups. Now, of course, the comment is, can we extrapolate the primary results, which we will talk about in a minute, I assume, to the group now? Because now everybody is on an SGLT2. And I already think, yes, the answer will be yes. Why? They work synergistically. SGLT2s have been proven to increase a little bit of diuresis, but they don't increase natriuresis. They only interfere with 5% of the sodium uptake in the kidney, while acetazolamide interferes with 60% of the sodium uptake in the kidney. So they work completely different.
Okay. And you've already alluded to the primary treatment effect, so tell us what that is.
Yeah, we kept the best for last, Harriette. So the primary endpoint was, is your patient dry, based on absence of edema, pleural effusion, ascites, after 3 consecutive days of diuretic therapy. And we hit the primary endpoint overwhelmingly. We had a 46% improvement in decongestion. So 46% more people were decongested after 3 days of consecutive diuretic therapy. This was with a p-value of 0.0009, tremendously effective. Number needed to treat was around 8 only after 3 days. What's more was that the therapy led to a reduction in hospitalization. That was a secondary endpoint. So we saved 1 day of hospitalization, which will reduce healthcare related costs and also will probably improve quality of life sooner. And then you can wonder, does the therapy really help, or can I make it up if I don't do it initially? So we also collected data at discharge. And it was clear that the benefit of acetazolamide was maintained at discharge. There too, there was a statistically significant increase in the number of patients decongested at the moment of discharge. The reason for that is there are 2 reasons. First of all, acetazolamide increases natriuresis a lot more than diuresis. And secondly, we noted an incremental benefit of the drug over consecutive days. So that means you cannot make it up. We have to treat congestion early on and very aggressively with a combination of diuretic agents.
Now, because your comparator group had placebo versus an equivalent added dose of a loop diuretic, how do you know that the treatment effect is due to acetazolamide rather than just higher dose equivalence of a diuretic agent?
Well, that's hypothesis generating,
Right?
Harriette. And of course, that might be true. And you might now ask the question, what would have happened if we would have given a thiazide, for example?
Yeah, that could have been another.
Why don't you do the trial?
I would potentially agree to doing a trial, except that my focus is health services implementation, although this would be a really great question to answer.
I couldn't agree more, but we have to stick to science and to data that we have.
Yes.
So we set up the trial like this, and I think this is the first trial now
So exciting.
in acute heart failure that shows that you can decongest better in a safe manner. We didn't touch upon that. It's easy to use and it's off patent. So the drug is almost for free.
Yeah.
So I don't see any, of course you have to be critical about the data, but I don't see any reason why we cannot deploy or employ this strategy tomorrow.
And how do you continue on therapy beyond the hospital stay?
Yeah.
Any ideas?
Yeah, so our thinking in the heart failure world has always been, my thinking has always been, the initial phase is all around decongestion. You have to get rid of the fluid out of your body, and then of course you install the goodies, the disease modifying agents. The disease modifying agents will kick in a lot better in an environment where the congestion part is relieved. Those medications, the disease modifying agents, aside a little bit for the SGLT2s, will not decrease the congestion acutely. The patient comes in suffocating with a lot of edema, That is the target for diuretic therapy. And acetazolamide now is unequivocally proven to do a better job in combination with loop diuretics than loop diuretics monotherapy.
Right. So no plans, or not the continuation of acetazolamide was not sort of
No,
part of the
it's not
protocol or planned investigation.
No, it's not part of the protocol, so I cannot
Yeah.
say it's safe to give it on an oral
Long-term.
basis long term. We don't have the data to say so.
Yes.
It may be helpful, but again, I think diuretic therapy should be temporarily
Yes.
during the decompensation phase, and then we have to lower down, hopefully stop them, to increase the dosage of the neuromonal blockers.
Absolutely. Two important points. Thank you so much for your discussion with us. Congratulations on a beautifully run trial and its impact on clinical care, providing us with more in the armamentarium to decongest patients and help them feel better following decompensated heart failure. Thank you, Professor Mullens.
Thank you for having me.